Welcome to another edition of Health in the Heartland, a program dedicated to the health issues that affect you, your family, and our community. You probably have heard that blocked or narrowing arteries is a major risk for coronary artery disease. Well, guess what? That plaque buildup, which is called fatty material in your arteries, not only affects your heart, but also affects other arteries throughout your body and puts you at major risk for stroke, aneurysm, and even amputation. Fortunately, joining us this episode is Dr. Henry Veldenz, who's going to speak with us about such vascular diseases and talk to us about risk factors and treatments. Dr. Veldenz, thanks for being here with us.
Good morning, thank you.
We'd like to start a little bit about, we've talked about stroke, and let's maybe start with that and some risk factors and who would be at risk for stroke.
Well, patients with any vascular disease are at increased risk for stroke. So if you already have something like coronary artery disease or prior lower extremity arterial disease, you already are at increased risk of stroke because hardening of the arteries or atherosclerosis is a systemic disease. It affects every blood vessel in the body, not just one particular bed or territory. A positive family history is always a risk factor for any disease, and particularly so in stroke. Diabetes is a strong risk factor for stroke from atherogenic or vascular causes. Carotid artery disease probably is responsible for over half the strokes in the country.
Now, when we talked about the risk, of the plaque buildup in our arteries, we usually generally think of our heart, but we really understand that it affects all of our arteries throughout our body.
Correct.
So not only our heart, but it can put us at risk for this plaque buildup that can even lead to problems with the stroke with our brain. What about our legs or other parts of our body, something called PAD? Explain to us a little bit about
peripheral arterial disease. Because it is a systemic disease that affects every blood vessel in the body, it can affect the aorta as it comes off the heart. Other blood vessels that come off the aorta then also can be involved, such as the carotid artery, like we talked about with stroke. The aorta, once it enters the belly, can start to harden and narrow and cause blockage and lack of blood flow to the legs. Those blockages can continue further down in the femoral vessels in the thigh or the tibial vessels in the calf. All of those can get occlusions or narrowings from hardening of the arteries and atherosclerosis. Another important problem with hardening of the arteries in the aorta is some patients have a tendency that instead of narrowing up the artery, the first response of an artery when it wants to be blocked is to try and dilate to provide more blood flow. In some patients, that artery enlarging or dilating as a compensation mechanism becomes uncompensated, and that artery can dilate to what we call an aneurysm. That basically becomes something like a balloon. The wall gets thinner and thinner, the artery gets bigger and bigger in diameter. That thin wall becomes like an eggshell, fragile, hard, fragile, soft, and it can break and rupture if it's large enough. And that's where an aneurysm comes in from hardening of the arteries.
Which is very much an emergency situation.
A ruptured aneurysm is a life-threatening emergency. Half the patients who have a rupture of an abdominal aortic aneurysm never make it to anybody in time. Of half the patients that come to a health provider while still alive, realistically, we only save about half of them with emergency surgery.
So what type of population would be at risk as far as like age bracket for aneurysms or peripheral artery disease, or is there a distinction between the two?
There is a distinction between the two, and again, one important element that I always believe in is family history is very important. You get a lot of gifts from your mom and dad. Some you can't give back, and if dad had an aneurysm, if your brothers have an aneurysm, there's a high tendency that you may very well also have develop an aneurysm. So certainly somebody with that in their family needs to know that, and they automatically are in a higher risk population. Patients with uncontrolled hypertension are at increased risk of developing any hardening of the artery or atherosclerotic problem, and hypertension also is its own independent risk factor for development of an aneurysm. Far and away, the biggest controllable risk factor that patients can work with is smoking. I can honestly say in my career, for every aneurysm I have seen and treated in a non-smoking patient, I will see 19 people who have smoked in their lives. Now, if you've quit smoking, that can help you stop the progression of your aneurysm, stop it from growing if you have one, or maybe never develop it. But once the smoking damage has hit the blood vessels, particularly in somebody who has a tendency, because of family history of aneurysm disease, they are at increased risk of continuing to develop an aneurysm over the rest of their life. There are Medicare guidelines for screening for abdominal aortic aneurysm with ultrasound. If you have never had a imaging study and you are 65 and older and have any of the basic risk factors, you can get a screening ultrasound under Medicare to see if you possibly have an abdominal aortic aneurysm. Another important method of screening for the aneurysm is having a good relationship with the primary care provider. Many aneurysms can be found just with the simple physical exam of a physician laying hands on a patient's abdomen. In a thin enough patient, I can feel the aneurysm if it's there or not. I can feel if it's a large aneurysm or not. Obviously, as America gets larger and larger in size with obesity, it is harder for the hands sometimes to feel that, and that's again where ultrasound can be very important.
And you did just mention obesity, and I was wondering, you know, we've talked about smoking and age, I think, a little bit with the risk factor. Is obesity then with our diet that can lead to the plaque buildup too, correct?
Well, that's a tougher question to really resolve. I guess I would consider obesity a soft or a secondary risk factor. Obesity will lead to diabetes, which is 2 to 3 times the risk of any other risk factor. Obesity leads to hypertension, which is its own independent risk factor worth a point. There have been some studies that have shown that obese patients have a higher rate of atherosclerotic events. There are some studies that have shown that that may be neutral when you account for what the other secondary effects that obesity does to the body.
We've talked about the screening for the aortic ultrasound and looking for an aneurysm there. What are some other screenings that individuals might talk to their primary care professional about having for vascular diseases?
Well, first off, I have to say in the beginning, screening is to try and pick up a pathologic disease or state in an asymptomatic patient. If you have symptoms or signs, obviously that no longer becomes screening but becomes potentially diagnosis. And again, the primary care provider could help navigate that. To truly screen somebody for an asymptomatic disease, it's of benefit when you have potentially a high enough prevalence disease across a broad population that cannot be detected otherwise with symptoms. Carotid disease can be looked at with duplex ultrasound. Safe, non-ionizing radiation, reproducible, and in accredited laboratories is also very accurate for determining how significant the plaque buildup may be. Most carotid screening studies will not show significant disease that needs an operation, but there are many patients that may have early mild plaque or moderate plaque that, if nothing else, has now identified themselves as having the onset of the systemic disease in general, which would hopefully then point out the role of stronger and more aggressive primary risk factor control in their treatment regimens. Who should be screened for carotid with an ultrasound? And again, I'm talking pure asymptomatic with no signs or symptoms. That's a kind of a tough call as the literature goes on. Asymptomatic carotid disease is not quite as virulent in its progression as it used to be 20 years ago. We have much better treatment of high blood pressure today. The cholesterol medications have been an amazing advance over the last 20 years. So if you look at the advent of treatment of cerebral vascular disease and risk factors, antiplatelet therapy is much more pronounced than it used to be 20 years ago. But certainly somebody with a family history, somebody who has a history of other atherosclerotic beds already identifying they have a systemic disease, that may be a patient who is worthy of screening with an asymptomatic carotid duplex. We talked about which blood vessels are involved, and it's more than just a heart. I sometimes have told patients who present with problems and they wonder why I'm here for my legs being blocked arteries. Why are you looking at my neck? It's like a horse race. And you've got 6 or 7 horses galloping for the finish line. As you're rounding the turn, the legs may be in the lead, but either the coronary artery disease or the carotid artery disease or the aortic aneurysm start galloping up on the outside and want to cross the finish line first. All the blood vessel beds are in play. And something that's been fascinating after doing this for 20 years is why different patients have different arteries present with their atherosclerotic syndromes at different times. There can be patients who only seemingly have coronary artery disease that symptomatically present. There are other patients I have had that all I've ever done on them is work on their lower extremity blood vessels. With respect to the screening of carotid disease, it's safe, it is simple. Understand that for determining if you have a carotid lesion that actually needs potentially interventional or surgical treatment to prevent a stroke, you're not going to have that many positives screening populations of hundreds of patients. However, it can become a very important factor for picking up people who are having atherosclerosis that need systemic risk factor control.
So generally, if I'm understanding, as we're talking about screening, that's something that is personal, based upon your family history, based upon what's going on with your family physician, and not something that the general population necessarily needs to be screened.
Well, and again, the general population needs to probably be defined by their risks. Should I take a healthy 20-something nurse with no risk factors and screen her carotids? No. Is there a 64-year-old gentleman who's already on 2 agents for blood pressure who used to smoke up until 5 years ago? That patient may have a more likely rate of having carotid artery disease. And then the question is also the significance of that carotid artery disease. One other problem with screening is that there can be complications from the screening. Some tests will find what's called a false positive. And you start to go chasing what is you think a bad thing, and you find out it isn't. It was an artifact of the imaging or a problem of the test, and then a complication of that workup can occur. Fortunately, when screening for vascular disease states, ultrasound is very safe, and in good hands with good labs that are accurate, is also subjected to a very low rate of false positivity. The problem will be is we're not going to find that many people if we just take 300 30-year-old Walmart shoppers and ultrasound their neck. If you, now, again, you have a strong family history, you're 33 and your brother had a heart attack at 28 and your sister already had a stroke at 31, you're a different population. Right. You already know you're at increased risk compared to the general public. The only Medicare approved where Medicare will pay for screening is for abdominal aortic aneurysms in males over 65. And it can be extended to females, but they need to have additional risk factors that would imply that they might be higher prevalence, because aneurysms are more common, significantly more common in the male population than in the female population.
You shared some great information with us, because I think a lot of individuals, you hear the screening process and you really have to look at your own personal history, you have to look at your family history, your lifestyle habits. We've talked about smoking.
Correct.
And different things too. So definitely partnering with your healthcare professional, talk to them, about your risk factors and the potential if you do need to be screened.
One element of screening with ultrasound we offer here at the Heartland Memorial Health Center Vascular Laboratories is a screening package. There are, I'm sure, have seen many mobile here will come to the church and screen you for various diseases and processes, and it's certainly valuable to have that available to the community. But we have readily available parking. We have an iCable accredited vascular laboratory, which is the commission that checks vascular labs to make sure that they are truly accurate in their modalities to diagnose disease. We offer a screening package that we think is very financially competitive and reasonable for the patient on carotid disease, the presence or absence of an aortic aneurysm, and to screen for peripheral vascular disease in the lower extremities with an ankle brachial index. That package is very readily available here, and it is something that I think, because we have such excellent staff doing it, you can be confident that if something is picked up, it is something that then when you take back to your primary care provider, they can use.
And Dr. Veldenz, I believe no physician order is required for that, correct?
Correct. A patient can present to either of the 2 vascular lab centers on the health center campus and can get a vascular screening package, as we call it. We offer all 3 together. We offer each one individually if that is something that the patient would so choose to have. But again, I really would like to emphasize that the experience of our technical staff and the rigorous attention to accuracy makes it a valid study when you get it.
And a very easy way to do that is by calling 706-5444 and hitting option 5, or of course they can visit our website at www.hmh.net. But great opportunities for people to find out their risk factors right here in the community and take advantage of that package.